Hello.
Hello.
Please, can we see my screen?
Yeah, we can see.
Okay.
Okay, so who is reading for us?
Please, I'll read.
Okay.
So, number 1, proximal DVT refers to venous thrombosis in all the following except A. Peroneal vein, B. Iliac vein, C. Femoral vein, D. Popliteal vein.
Okay. So what are you going for?
Peroneal vein.
Yeah, peroneal. So that's distal DVT. So the rest are proximal. Okay.
Okay. 2, all the following are late complications of deep vein thrombosis except
Okay. So the options.
A. Chronic thromboembolic pulmonary hypertension. B. Pulmonary embolism. C. Post-thrombotic syndrome. D. Recurrent thromboembolism.
Okay. So what are you going for?
Um, Post-thrombotic syndrome.
Okay. Any other answer?
Recurrent thromboembolism.
Okay. Any other answer?
B.
Pulmonary
B.
embolism.
Pulmonary embolism.
Okay. Pulmonary embolism. That's true. So when you have DVT, what you are afraid of is the immediate complication of pulmonary embolism. So all of them are late complications. But in terms of the one which is an early complication you're afraid of, that's pulmonary embolism. So the rest are late complication. But pulmonary embolism is early complication.
Okay. Okay. 3, all the following are oral factor 10A inhibitors except A. Edoxaban, B. Fondaparinux, C. Rivaroxaban, D. Apixaban. Fondaparinux.
Yeah, so fondaparinux, though is a factor 10A inhibitor, but it's an injectable preparation. The rest are oral.
Okay. Number 4, initial parenteral anticoagulation is not required for all the following factor 10A inhibitors except A. Rivaroxaban, B. Fondaparinux, C. Edoxaban, D. Apixaban.
Okay, so what are we going for?
C.
Edoxaban.
Edoxaban.
Yeah, so those are banned. So with that one, you have to do a 5 to 10 day parenteral anticoagulation before you can do doxapan. But the rest you can start straight away.
Okay. Number 5, the following are components of the Wells score for DVT except A. Swelling of the entire leg, B. Active cancer, C. Previous history of DVT, D. Bedridden for longer than 3 days. Swelling of the entire leg.
Okay, so what are you going for?
Swelling of the entire leg.
Previous history.
Okay. Any other answer? Any other answer?
Active cancer.
Well,
Okay. So all of you are going for active cancer and swelling of the entire limb.
C.
Yeah, so previous history of DVT. Remember I told you we have raw score and we have modified raw score. So previous history of DVT is not part of the raw score, but it's part of the modified raw score. So that's the additional parameter in the modified raw score for DVT. Previous history of DVT.
okay. 6. D-dimer is highly specific but not sensitive to DVT. True or false?
False.
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 Okay, so that's false.
7. All these conditions can cause D-dimer elevation except A. Sepsis, B. Malignancy, C. Digital rectal exam, D. Pregnancy. Digital rectal exam.
Digital rectal exam.
Exactly. So the rest can cause elevation in D dimers, except DRE.
Okay. 8. All these are false about D-dimers except A. Can be elevated in renal failure. B. Has a high positive predictive value. C. It's a fibrinogen degradation product. D. Has a high negative predictive value.
Okay, so what are we going for?
D.
Has a high
Has a
negative
high
predictive.
negative predictive value.
Okay, is that what all of you are going for?
Yes.
A and D.
Hmm?
So is everyone going for D?
Yes, please.
But isn't it a degradation product of fibrinogen?
No.
Oh, why?
It's fibrin degradation, not fibrinogen.
Okay. All right, so there are actually two answers here. So the answer is A and D. So it can be elevated in renal failure. Mm. So it's renally cleared. So when there's renal impairment, D dimers can also increase. And it also has a high negative predictive value. So it's A and D.
Okay. 9. Patients with heparin-induced thrombocytopenia are at an increased risk of bleeding. True or false?
False.
Okay, is everyone going for false? Any other opinion? Okay, so that's a false statement. So we said heparin-induced thrombocytopenia is used for type 2 hit. So for type 2 hit, it's associated with thrombosis. But if you are talking about type 1 hit, that is not associated with thrombosis. The patient may bleed. But the moment you hear of heparin-induced thrombocytopenia, it's in relation to type 2. If you hear of heparin-associated thrombocytopenia, it's in relation to type 1. Okay, let's move on.
Modeling agents is ideal for managing heparin-induced thrombocytopenia. A fragment, B. Xarelto, C. Fondaparinux, D. warfarin.
Which one are you going for?
Fondaparinux.
Yeah, fondaparinux. So when someone has heparin-induced thrombocytopenia, you want to avoid heparin products, you want to avoid warfarin, but you can do fondaparinux in such instance.
Okay. 11. Which of the clotting pathways requires the presence of a tissue factor? A. Intrinsic pathway, B. Extrinsic pathway, C. Common pathway, D. Contact activation pathway.
Okay, so which one?
Extrinsic pathway.
Yeah, so the extrinsic pathway. The extrinsic pathway.
12. Factor 10A is formed faster in intrinsic pathway than extrinsic pathway. True or false?
Okay, so what are we going for?
False.
False.
Okay, I'm hearing false. Any other answer? All right, so that's a false statement. So if you look at the steps in the extrinsic pathway, it's just 2 steps for you to form factor 10A. But when you look at intrinsic, the steps are longer. So it takes time to form factor 10A in the intrinsic compared to the extrinsic.
Okay. 13. All the clotting factors required for extrinsic pathway are found in circulating blood. True or false?
So what are you going for? Which one are you going for? Is it a true or false statement? All right, so looking at the term, we are talking about extrinsic. And extrinsic, something has to induce. So the tissue factor that is released is because of trauma. And that trauma to the tissue will cause the release of the tissue factor. So it's not found circulating in blood. So for extrinsic pathway, all the factors required are not found in circulating blood. So that's a false statement.
Okay. 14. The activity of warfarin is best measured by doing the INR assay, which measures the extrinsic and common pathway. True or false?
So
False.
which one are you going for?
INR target extrinsic.
Is it a true statement or a false statement?
Is it true?
True statement.
Yes.
Yeah, so that's a true statement. So offering activity is measured with INR, and the factors that are inhibited by warfarin, most of them are found in the extrinsic and common pathway. So most of them will be found in the extrinsic and common pathway. So using the INR for extrinsic and common pathway gives a reflection of the activity of warfarin.
Okay. 15. The activity of heparin is best measured by doing the APTT assay, which measures the intrinsic, extrinsic, and common pathway, true or false.
So what are you going for?
False.
Yeah, so that's a false statement. So it will only give a reflection of the intrinsic and common pathway. So that's why we use APTT to measure. So that will tell you the activity of heparin.
Okay. Match the following statements to the key below. So A, warfarin, B, unfractionated heparin, C, clopidogrel, D, rivaroxaban, E, donaparoid, F, dabigatran. So 16, indicated in the management of heparin-induced thrombocytopenia.
Which of them?
Mhm.
Dabigatran. Rivaroxaban.
Okay, any other answer?
Dabigatran.
Okay,
Danaparoid.
I've heard the bigatron. I've heard
Mhm. Dabigatran.
rivaroxaban. I've also heard danaparid. So which is which?
Dabigatran.
It's danaparid.
Mm. Okay. Okay. Potentially
The next one.
thrombogenic.
Warfarin.
Yeah, so warfarin is full thrombotic.
18. Concomitant administration with omeprazole should be avoided.
Clopidogrel.
Clopidogrel.
Girl.
Okay.
Clopidogrel.
Any reasons why? Any reasons why you should avoid that combination?
Because of the enzymes cytochrome 2C19, yes. Omeprazole will reduce the metabolism of clopidogrel through that enzyme, through inhibiting that enzyme.
Okay. So if you are saying omeprazole would reduce the activity of clopidogrel through that enzyme, does it mean that there will be accumulation of clopidogrel, so the antiplatelet effect will be increased, or does it mean that the antiplatelet effects will decrease?
Hello there. So clopidogrel is a prodrug which needs to be metabolized into its active form for it to exert its antiplatelet activity. So when omeprazole inhibits the enzyme, it will not be activated, so the antiplatelet activity will be reduced.
Exactly so. So what you need to understand is when you give clopidogrel, it's inactive. It's a prodrug. It has to be converted to the active metabolite. And this conversion is done by cytochrome 2C19. So if you give it concomitantly with omeprazole is a strong inhibitor of cytochrome 2C19. So it will prevent the conversion of clopidogrel into its active metabolite. And the antiplatelet effect of clopidogrel is derived from the active metabolite. So if you are not forming the active metabolite, essentially you are not getting any antiplatelet effect. So that's the consequence. So after identifying this interaction, how would you intervene? So what would be your recommendation? Should we space? Should we replace something? What should be the recommendation? And this is very common, especially if you are dealing with someone with MI, cardiac condition. Ideally, they may have been prescribed aspirin, but such a patient, if they have peptic ulcer, wouldn't be able to take aspirin. So the likelihood that the physician will switch the patient to clopidogrel is high. And you still also have to manage the ulcer. So it's likely that you also give omeprazole for the ulcer. So such patients, common patients, MI, they'll come with clopidogrel. They also come with omeprazole. So what would you do as a pharmacist? So the recommendation is to replace one of the agents, because if you space it, the interaction will still happen. So you want to replace. So you can replace the PPI with H2 receptor blockers, which do not have any interaction with omeprazole. But you know, the H2 receptor blockers are not as effective as PPIs. It's likely that clinician may still want to do a PPI. So in that case, if you want to do a PPI, you can either do lansoprazole, rabiprazole, or pantoprazole. So these are the ones you can do: lansoprazole, rabiprazole, or pantoprazole. Though all these are PPIs, but these are weak cytochrome 2C19 inhibitors, whilst omeprazole are strong cytochrome 2C19. So if you want to do a PPI, lansoprazole, rabiprazole, or pantoprazole, that can be used to replace the omeprazole. All right, let's move on.
Okay, 19. Reversed with potassium sulfate.
Which of them?
Unfractionated heparin.
Okay.
20. Can cause calciphylaxis.
Which of them?
Warfarin.
Yeah, warfarin. So that's one of the rare side effects of warfarin. Calciphylaxis, where there is deposition of calcium around the blood vessels and tissues, can cause necrosis. So it's one of the rare side effects of warfarin. Okay.
Dr. Isaac, please, the line got broken around the part where you said the lansoprazole, rabiprazole, and pantoprazole are weak cytochrome 2C19 inhibitors. So the rest I couldn't hear. Could you please go back? Thank you.
So that's what I said can be used to replace the omeprazole or esomeprazole. The omeprazole, esomeprazole are strong cytochrome 2C19 inhibitors. So because of that interaction, if you want to do a PPI, you can either do lansoprazole, pantoprazole, or rabiprazole, because these are weak cytochrome 2C19 inhibitors.
Yes, please. Thank you.
21. Reversed with idarucizumab.
Yeah, so that's true.
22. Apixaban is not recommended in all the following except A. Pregnancy, B. Phlegmasia ceruleus dolens, C. Massive pulmonary embolism, D. End-stage renal disease.
So which of them?
Please, I didn't hear the discussion for 19 and 20. I'm so sorry that my line got cut. I couldn't hear anything. What did I hear is 21. The answer is F.
Hello. So which one are you going for?
End-stage renal disease.
Yeah, so that's true. It's not recommended in pregnancy, phlegmasia ceruleus dolens, also in massive P. So for massive P phlegmasia, you said you use thrombolytics. For pregnancy, the recommended one is the heparins, either the unfractionated or low molecular weight, because they do not cross the placenta. So those are the recommended. But if you have an end-stage renal patient, you can even use apixaban. So it's recommended in such patients. Okay.
Okay. All these are advantages of direct oral anticoagulants compared to warfarin, except A. Similar efficacy with warfarin, B. Less bleeding risks, C. Readily available antidotes, D. No monitoring required.
C.
Yeah, so all the rest are advantages for direct oral anticoagulants over warfarin, except the readily available antidotes. So when you look at the antidotes for the direct oral anticoagulants, if it's the apixaban, rivaroxaban, you know that you have to use andesonate alpha, which is not readily available. Dabigatran to idarucizumab, which is not readily available. But warfarin antidote vitamin K is readily available. So that's the exception in there.
Okay. 24. Which of the following agents is the preferred long-term agent for anticoagulation in a pregnant woman? A. Rivaroxaban, B. Enoxaparin, C. Warfarin, D. Dabigatran.
So which one are you going for?
Enoxaparin.
Okay. Do you agree? For long term, you can use enoxaparin for long term. Do you agree? Or any other answer? So we said enoxaparin can be used for both initial and long term. So for pregnant women, you want to use something that's safe for the mother and the fetus. And enoxaparin doesn't cross the BBB. It doesn't cross the placenta in significant amount to cause any harm to the baby. So it can be used for long-term therapy in pregnant women.
Okay. Use the key below to answer the following questions. A. First statement is true. Second statement is true and is a correct explanation of the first. B. First statement is true. Second statement is true, but not a correct explanation of the first. C. First statement is true. Second statement is false. D. First statement is false. Second statement is true. E. Both statements are false. So 25. Heparin injections containing benzyl alcohol should be avoided in neonates because benzyl alcohol in heparins can cause gray baby syndrome.
Okay, so what are you going for? So first statement, is it true or false? Heparin containing benzyl alcohol should be avoided in neonates.
The first statement is true.
Okay, so the first statement is true. Okay. What about the second statement? Was benzyl
The
alcohol
second
cause
statement
gray
is
baby syndrome?
false. It causes Gasprin syndrome.
Exactly. So we are avoiding benzyl alcohol in neonates because of the risk of Gasprin syndrome, not gray baby syndrome. Which medication causes gray baby syndrome?
Chlorophenical.
Yeah, chloramphenicol.
Twenty-six. Heparin has a greater affinity at inhibiting thrombin compared to enoxaparin because enoxaparin has no effect on antithrombin.
Okay, so first statement, true or false? So heparin has a greater affinity at inhibiting thrombin compared to enoxaparin. Is it a true or false statement?
True.
No, so that's a true statement. Then the second one, enoxaparin has no effect on antithrombin. Is it a true or false statement?
False.
So that's false. So it's true, false. C.
27. Dalteparin does not require routine monitoring compared to unfractionated heparin because it has a more predictable anticoagulant response compared to unfractionated heparin.
So first statement, is it true or false? So dalteparin does not require routine monitoring compared to unfractionated heparin. Is it a true or false statement?
A true statement.
So that's true. So what about the second statement? Because it has a more predictable anticoagulant response compared to unfractionated heparin.
True.
Okay, so both statements are true. Related or unrelated?
Related.
So they are related. So that's A.
Okay, 28. Rivaroxaban should always be taken with meals because food increases its bioavailability and peak concentration.
Okay, first statement, true or false?
False.
False.
Yeah, so that's a false statement. You take it with meals for higher doses. Lower doses, with or without. Okay, second statement, true or false?
True.
Okay, so that's false, true. B.
29. Warfarin preferred over rivaroxaban in patients who require anticoagulation with a history of GI bleeding because warfarin is associated with lesser risk of GI bleeding than rivaroxaban.
Okay, so first statement, true or false?
False.
Okay, second statement, true or false?
False.
Do you have any opposition? All of you are going for the same.
Look, I'm thinking true, false.
Okay. Any other answer? So the answer is actually A. So warfarin is preferred over rivaroxaban in patients who require anticoagulation with a history of GI bleeding. So if the patient has a history of, say, gastritis or GI bleeding, and you want to do anticoagulation between warfarin and rivaroxaban, it was realized that in terms of the incidence of GI bleeding, warfarin had a lesser incidence of GI bleeding compared to warfarin. So it's preferred over, no, warfarin is preferred over rivaroxaban for patients with history of GI bleeding, all because the risk of GI bleeding was lower when it was compared to rivaroxaban. But when you're looking at general bleeding tendencies, warfarin tend to have a general higher bleeding tendency. But if you are being specific about GI bleeding, warfarin and apixaban, if you want to do factor 10A inhibitor for someone with history of GI bleeding, apixaban is preferred over rivaroxaban, and warfarin is preferred over rivaroxaban because of lesser risk of GI bleeding. Rivaroxaban and dabigatran tend to have higher risk of gastritis and GI bleeding. Let's move on. Hilary, are you there? You can't see your screen. Hello, Hilary. Can someone take over the sharing of the screen? I think Hilary has left. Hello, is anyone taking over the sharing of the screen?
Please, can you see the screen? Can you see what's on the screen?
Please.
Hello?
Yeah, we can see.
Yeah, we can see.
Okay, so we're on question 30. Concomitant administration of phenytoin and rivaroxaban should be avoided because phenytoin causes reduction in the level of rivaroxaban by inducing cytochrome 2C19.
Okay, so what are you going for?
True, false.
So the first statement is true, but the second statement is false. So we are avoiding it because of the fact that phenytoin can induce cytochrome 3A4, not 2C19. So we said rivaroxaban is a substrate for cytochrome 3A4. So if you induce cytochrome 3A4, what you are going to do is you are going to reduce the serum levels of phenytoin. So the patient is supposed to be on some maintenance dose of phenytoin to control the seizures. Patient may be getting breakthrough seizures because you don't have enough levels of phenytoin to control it. Okay.
Hello, Doc, please can you take
Question
the
31. Green leafy
hello?
vegetables.
Hello, Doc, please can you take the explanation in again? Your line broke off.
Yeah, I was saying rivaroxaban is a substrate for cytochrome 3A4, not 2C19. So phenytoin will induce cytochrome 3A4 levels, and that will reduce the serum levels of rivaroxaban. Oh, sorry. So when I was explaining, I changed it. So it will reduce the levels of rivaroxaban. So that will reduce the anticoagulant effect of rivaroxaban.
Thank
Question 31. Green leafy vegetables should be avoided in patients taking warfarin because green leafy vegetables can alter the INR target of warfarin.
Okay, so what are you going for?
False, true.
False true.
Yeah, so false true. So that's D, false true.
Um, Question 32. Vitamin sulfates should be avoided in patients without heparin overdose.
So I think this question, I made a mistake. So you should have read protamine sulfate should be avoided. So you cancel the not. So it should be avoided in patients without heparin overdose because protamine sulfate has anticoagulant effect and can cause bleeding. So you answer it that way. So what are you going for?
True.
Okay, so you are going for true. Related or unrelated?
Related.
Yeah, exactly. So protamine, even though the antidote for heparin, if the patient doesn't have heparin overdose, please avoid protamine sulfate. And this is because protamine sulfate has intrinsic anticoagulant effect and can potentially cause bleeding. So we said that heparins, so does it make sense that we have heparin, which is an anticoagulant, the patient is bleeding from it, and we are supposed to give an antidote. And this antidote also has anticoagulant effect. Does it make sense at all? Any reasons for that?
Use, use the key below to answer the following questions.
No, you've
A.
not answered the
I
question.
sorry.
Yeah. So I'm asking whether it makes sense for us to use protamine sulfate to neutralize or to serve as an antidote for heparin. Because this protamine sulfate you are talking about has intrinsic anticoagulant effect. And the patient is bleeding from heparin. So why would you want to give another agent which is an anticoagulant?
So you explained the other time that
Mm.
protamine is positively charged and heparin is negatively charged. So for the protamine heparin complex, protamine is able to completely neutralize the negative charge of heparin. So at the end of the day, it loses that effect.
Exactly. So once we have protamine which is positively charged, neutralizing the negatively charged heparin, you form a neutral complex which doesn't have any anticoagulant effect. So their anticoagulant effect also neutralizes out. So that's why we can use protamine to neutralize heparin. So if the patient doesn't have heparin overdose and you go and give protamine, the patient can potentially bleed because there's no heparin to be neutralized by protamine. All right, let's move on.
Use the key below to answer the following questions. A is and I. B, and I. C, and I. D, I only. E, I only. Question 33. Side effects of heparin include hyperkalemia, osteoporosis, thrombocytopenia.
Okay, so which one are you going for?
A.
So A, all of them. So it can cause osteoporosis, thrombocytopenia, and hyperkalemia.
Question 34. Rationale for overlapping warfarin therapy with enoxaparin include all except I. Warfarin is prothrombotic. II. Warfarin has a delayed onset of anticoagulation. III. Warfarin has activity on already formed clots. I think it's E.
B.
E.
B.
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 B. B.
So what are we going for? I've gotten different answers. So which one is which?
Please, I think it's E.
Okay, I'm hearing E. Any other answer?
B.
B.
I'm hearing D.
B.
B.
B. Okay, B. So I've heard B, I've heard E. So which is which?
E.
So the answer is E. So when you look at all the options, so warfarin is prothrombotic, which is true. That's one of the reasons why we overlap. Then warfarin has a delayed onset of anticoagulation, which is also true. That's why we overlap. Then warfarin has activity on already formed clots, which is false. It doesn't have activity on already formed clots. It's new ones. So that's the exception. So that's E.
Question 35. Factor 10A inhibitors include I. Edoxaban, II. Apixaban, III. Fondaparinux.
Which one are you going for?
A.
A.
Okay. So the answer is A.
Question 36. Preferred anticoagulants in severe renally impaired patients. I. Warfarin, II. Dabigatran, III. Rivaroxaban.
D.
Okay, I'm hearing D. Any other answer? Yeah, so the answer is D. Warfarin is preferred in patients who have severe renal impairment. So it's preferred over dabigatran rivaroxaban.
Question 37. Preferred anticoagulants in severe liver impairment with high INR. I. Enoxaparin. II. Apixaban. III. Rivaroxaban.
Which one are you going for? Anyone?
D.
I'm hearing E. Any other answer? Any other answer? So the answer is enoxaparin. So that's the preferred. So that's D. Enoxaparin is a preferred.
Please, that's all. The questions are done.
Okay. All right. Any questions on what we've discussed so far? Or DVTP?
Hello, sir. Sir, please, can you
Hello.
hear me? Yes. Okay, sir, please, I have a question for the ninth question. Patients with heparin-induced thrombocytopenia are at an increased risk of bleeding. You gave an explanation, but I didn't really get you. So please, I would like you to come again with that.
So heparin-induced thrombocytopenia. I said that whenever you see the term heparin-induced thrombocytopenia, we are referring to type 2. I told you have type 1 heparin-induced thrombocytopenia, and we have type 2 heparin-induced thrombocytopenia. But the type 1 is now referred to as HAT. So HAT, heparin-associated thrombocytopenia, because they realized that heparin-induced thrombocytopenia is more of a misnomer. It doesn't really reflect what is actually happening. So type 1 is more physiological. When you give heparin, you can have levels of platelets going down, but you don't have to stop the medication. You still continue, the levels will normalize. But for the type 2 it's the one that is referred to as heparin-induced thrombocytopenia. And we said that one is immune-mediated. So when you give heparin, we said heparin binds to platelet factor 4. And once it binds to this platelet factor 4, the complex of heparin and platelet factor 4 is able to induce immune response. So it causes the immune system to produce antibodies against this complex. So you have antibodies coming to attack this complex. And once you have that occurring, you have another complex forming. So you have heparin, platelet factor 4, and antibodies. And these complex can cause platelet activation and aggregation. So you have a lot of platelets aggregating at one site. You know what can happen when you have platelets aggregating. You can have thrombosis occurring. And aside the thrombosis, what it leads to is the levels of platelets drop. So you can have thrombocytopenia as a result of that. So type 2 is associated with thrombosis, not bleeding. So if a patient will bleed at all, it will be from type 1. And that is not referred to as heparin-induced thrombocytopenia, but rather heparin-associated thrombocytopenia.
Yes, please. Thank you so much.
Okay. Any other question? All right, so if there are no other questions, let's quickly start a new topic. So I told you we'll be starting with a new topic today once we finish with the questions. So I told you to read on tetanus. So that's the topic for this evening, tetanus. Okay, so let's start. What do you know about tetanus? What have you read about tetanus? Anyone?
It's a bacterial infection that causes muscle spasms.
Okay. Okay, that's fine. The first thing I want you to know
Read that.
about
Okay, sorry.
tetanus. Okay, so someone is also talking. You can go ahead.
Okay, so I read that it's a bacterial infection that is caused by Clostridium tetani, which is a gram positive anaerobe, and then like it produces a neurotoxin, like which is responsible for the clinical like presentations. So some of the presentations are trismus, sardonyx. I don't know if I'm pronouncing it right. Yes, and then the neurotoxins we have tetanolysin, tetanospasmin. Yeah, and then there are like three types of it. We have cephalic, localized, and then the generalized. Sometimes like they include the neonatal tetanus as part of it. Yeah.
All right, so that's very good. It means you really read. So that's very true. All right, so basically, when we say tetanus, the first thing I want you to know about tetanus is an infectious disease. So it's an infectious disease. That's the first thing I want you to know about tetanus. So by being an infectious disease, it means that it's caused by an infectious pathogen. In this case, a bacteria. So it's a bacterial infection. So that's what we need to establish first. So it's an infectious disease caused by a bacterial pathogen. And specifically, the pathogen we are talking about here is called Clostridium tetani. So Clostridium tetani. So that's the first thing we need to establish about tetanus. The other thing I need you to know about tetanus is it's also a vaccine preventable disease. So when we say a vaccine preventable disease, what it basically means is when you are exposed to that infection, you can take a vaccine to prevent getting the infection. So if you are exposed, you can take a vaccine to prevent the full-blown infection. So that makes it a vaccine preventable disease. So that's another point we need to establish. So it's an infectious disease caused by Clostridium tetani, and it's also a vaccine preventable disease. When you go to other countries, it's also referred to as a notifiable disease.